This message goes out to the Indian government, to our honorable chair for this panel discussion. So we have an urgent message for the Indian government, which we want you to take back to the Prime Minister, Mr. Sri Narendra Modi, our Honorable Minister, Mr. J.P. Nadda, the Deputy Director General of the Central Division in India, Mr. Sunil Kaparde, to say that earlier this month, the World Health Organization has released its annual report on TB, which found that 29% of all TB-related deaths in the world occur in India. In fact, 1,400 Indians die each day of a preventable and curable disease. For instance, in my own state, back here in India, from where I belong, we have very poor infrastructure for addressing the burden of TB, and people are not aware of the basics of TB even, and that there is no spirit of partnership between implementing agencies and the civil society networks and the NGOs working out there. There is also a very big challenge in regard to the timely release of funds for TB-related programs, not necessarily from the ministry, but from the state government to the respective RTCP's state program. So this has been like ongoing for more than a year, or I would rather say that it's more than 2 years in fact. Now bringing it back to the national level, as of today, 662 days have passed since the Indian government has promised to roll out daily fixed dose combinations for people living with HIV and AIDS and children. Orders have been placed for the procurement, but is yet to be made available in the respective TB treatment centers. That being said, we demand that the Indian government fix the following 9 broken promises as laid down in this. I'll read out the 9 points. Number 1, to roll out daily FDCs for PLHIVs. Number 2, to roll out daily FDCs for children. Number 3, to scale up Gene Expert. Number 4, to scale up DST. Number 5, to roll out Bedaquiline. 6, IPT for PLHIVs. 7, IPT for children under 5 years of age. Number 8, Rifabutin for treatment of TB co-infection with HIV. And the last point, number 9, to stop using the category 2 for retreatment courses. In conclusion, the message is that mere political will without political action is not enough. We call for political action. We call on our Prime Minister, Mr. Sri Narendra Modi, our Health Minister, Mr. J.P. Nadda, and our respected DDG of the Central TB Division to take urgent actions and fix these 9 broken promises. And to all our comrades seated over here, abroad, as well as back there in India, to hold them accountable for not doing so. Finally, no more broken TB promises. Thank you. So we have our final message as we welcome that this is not what we want, so we're going to shout, shame!
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 Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame! Shame!
कहाँ से पागल लोग आ गया था?
Perfect. Thank you so much.
From where you brought this?
Thank you very much. Enjoy the rest of the session. Let's restart. Yeah, let's restart. So, thank you everyone. I think we're just going to reconvene this session, and I'd like to welcome Dr. Jagdish Prasad. Thank you for being here, sir. And we're going to quickly go into what is it that this symposium is about, which is the call to action for TB-free India. They wanted you to have a copy. That was to keep them outside. There you go. So the call to action for TB-free India is really funded through USAID Challenge TB project. It's led by the union. The goal really was to create and sustain high-level domestic commitment to end TB in India, with the objectives being increased domestic commitment and leadership to end TB in India, and really building comprehensive partnerships to mobilize resources and enable informed community engagement. When we started out this working with the government of India, the first thing we did was we wanted to launch this call to action by the government of the government, and we wanted to discuss what are the stakeholders that we want to engage in this campaign. We've realized that TB is too big a problem for the government to really tackle it alone. So when we talked to various stakeholders, we figured these are the major stakeholders that we want to reach out to. One is the corporate sector, the private health sector, where a lot of patients actually go for treatment, research and academia, media and celebrity engagement, really to drive more people to be aware that there is a TB problem, donors, NGOs, civil society partners who can actually go out there and do work in the community, parliamentarians, because really what we need for TB, for a TB-free India, is much more resources, much more political will to actually tackle this disease, to end it. And finally, TB survivors, patients, cured patients who have lived through TB and can share their tale. Our approach really was threefold. We wanted to engage all these stakeholders, and we wanted to find champions who could go out there and talk about TB. We wanted to empower patients and civil society to speak up about the kind of experience they were having when they were going out to the private sector, whether they were getting the kind of treatment that they deserved, whether they were getting the diagnosis that they were seeking. We also wanted to expand resources for TB. And I think that's one of the major aims of the call to action, was to how can we come together to expand resources, expand engagement and partnerships, and therefore increase visibility. The outcomes that we're seeking through the call to action is wide stakeholder engagement, increased political leadership and domestic commitment for TB, increased visibility of TB, and finally, increased resources for TB. And we really hope this all of this is going to work together and deliver a TB-free India. We had the launch of the call to action for TB-free India on 23rd April 2015 by the Honorable Minister of Health, Shri J.P. Nadda. The entire government, WHO, whole lot of civil society, Stop TB Partnership, the union, we all came together, and a lot of civil society partners came together to say that yes, we are going to work together to make India TB free. So have we really, moved the button, or have we really moved this? So I would say yes, in a way, because right now we have the Prime Minister Narendra Modi taking stock of the TB situation. He talked about it in his Man Ki Baat, which is his public address, which he does from time to time. And TB was one of the prominent issues that he addressed in this. We have several others who also joined us in making TB a known. I think the biggest challenge in India is that people talk about dengue, they talk about chikungunya, they talk about other diseases, but nobody seems to be talking about TB. So really we have other prominent names and faces who've joined us. We have Mr. Bachchan, who's a TB survivor, and you heard his message yesterday. We have Dr. Naresh Trehan, who runs a private hospital in Gurgaon and who's also committed to working on TB. We have Ratan Tata, who was part of our engagement, and post that has launched the India Health Fund, which is a fund in India for TB and malaria. And we have parliamentarians, that is Dr. P.J. Kurian, and on the bottom right, and there's Biplov Thakur. Both of them, they are from the Rajya Sabha, and P.J. Kurian is the Deputy Speaker. And they have also committed that they are going to increase parliamentarian engagement so that we have more focus on TB in the issues that are addressed in Parliament on health. We have several people pledging support. This is US Ambassador Richard Varma, who actually engaged with Mr. Bachchan and Mr. Tata. Ratan Tata has actually said that an appeal that it's about time that corporates and communities collectively respond to end this epidemic in our country. Tata Trust wholeheartedly supports this national movement against TB and will do everything in their capacity to contribute towards making it a success. We had an engagement plan with civil society. Around 45 civil society members came and joined, groups came and joined, organizations joined us, and they have shared a recommendation of what they think the government should be doing. And we shared this recommendation with the government, with the Central TB Division, and with the Ministry of Health and Family Welfare. We also engaged, like you saw, there were two parliamentarians whom we first appealed to, and they helped us reach out to the Chief Minister of Himachal Pradesh, and through him the Health Minister. And we had this engagement sensitization session in Himachal, where we found after our dialogue with them, they did 2 or 3 things that was absolutely, what does success look like in an advocacy project? This is what it looks like. You had the Health Minister committing that he will launch a nutrition support program for MDR patients in Himachal. He went out and he did a PRI engagement, and while he wanted to do this, he said this is going to be made available through the state distribution system, and he said that from now onwards, this nutritional supplement for TB patients is something that he's going to is announced, and it's available for TB patients. So this is how we really think this kind of a movement of engagement and dialogue can go on. So really, this is where we are at after a year of work. We have 15 corporate partnerships, large partnerships with known corporates, one of which is here with us. We have private health sector, one of which is here with us, Medanta, who's going to join us and share with you their project on TB. We have a lot of research and academic institutions. There's a North Maharashtra University and 7 West Zone universities who've come together to say they are going to undertake research work on TB. We've got 499 articles in this year on TB in media, after we started engaging with the media and telling them to write about it. And we have Mr. Bachchan's wholehearted commitment to this cause. We also have partnerships with Rotary India, which we believe, because they can really galvanize support at the ground and change the way we approach TB. And just like now I had said, we have parliamentarians engaged in our campaign. We have TB survivors, one of which is here with us today to share her journey, her story, and so she's going to talk about it. We have several partnerships with known organizations. So there's DLF Foundation, Tata Trust, there's Medanta, there's Larsen & Toubro, NTPC, and we have Janssen and IHMR, Jubilant Industries, and several more. Amitabh Bachchan's engagement has actually grown over the period that we've been engaged with him. It started with one dialogue that we engaged him in, called the Mumbai Dialogue, where he tweeted about himself being a TB survivor and how everyone or each one of us has a role to play in it.
1 more minute.
Yeah, that's it. So then I'm just going to, this is the last of it. This is one of the survivor stories that I'm going to leave you with. It's a young boy called Vinod who shared with us his story and a message for everyone here. Okay, let's next.
Okay. So we can call the next this corporate partnership, Mr. Anand Rishi from Johnson. Recently, I think this Janssen has come forward to help the tuberculosis in India, and he will tell how he is going to participate in our NTCP. Yeah, please come.
Please come.
So, good afternoon, everyone. Difficult to follow the slot and fanfare that actually happened. But I believe one thing that we kind of forget is India is more of a TB story because of the population that it carries, not an incidence rate that we can talk about when compared versus other high burden countries. Having said that, Johnson & Johnson, in line with its credo that it has been working with various stakeholders, including the Government of India, on various aspects. And this is one such initiative wherein we want to support the great work that is happening by the Government of India, by Ministry of Health and Family Welfare. This is an initiative by Johnson & Johnson to go and look at or explore the missed cases that are possibly there, particularly in the mines across 3 states in the country. One initiative that actually call to action by union and an effort by Ministry of Health actually undertook.
Just click. Yeah, that's
Okay.
it.
So in terms as far as mining is concerned, it is more of a black hole for a lot of people, given the fact that not a lot of numbers are open in the public in terms of what is the incidence rate, what is the number which is actually suffering, and that is something that we wanted to explore. Basis limited study that has happened in South Africa, the incidence rate is at least 10 times versus the normal incidence rates. So these figures obviously were peculiar enough for us to kind of get interested, and when the proposal actually came from the Ministry of Health and from the union, we thought let's explore and let's put in our best effort to understand what is the kind of epidemic here. The project, so before you even get interested, let me share with you the real project is yet to be started. The development actually happened only early 2016, and we are working on the feasibility plan. We are working on operationalization of the entire plan to get the project started early next year. But before that, we have kind of a couple of things that we worked on. The idea again was to collaborate with various stakeholders in line with what the objective that India Ministry of Health carries, and look at not just diagnosis, but before that creating awareness in the states and in the mining zones in these states. And for that, the state that we have is Maharashtra, Madhya Pradesh, and Chhattisgarh, and the objective is to kind of go in the mining segment within these states. Very importantly, this is the kind of framework that has been firmed up after the discussion. So disease awareness, diagnosis, and then linking these patients who would actually come out of the entire program to the government centers, to the broader RNTCP program. And we, at this point of time, the discussions, and the concrete numbers are not there, but we are estimating to kind of screen at least 50,000 miners across these 3 states. So as I was sharing with you, there are a couple of things that we have kind of looked at completing within the number of months that have actually passed. We have actually received an approval, internal approvals, which is kind of a big and a red tape system, within some of the other companies also like us. We have received a third-party approval and proposal, and PHFI, Public Health Foundation of India, has been firmed up as the third party for us. And we have received clearance from internal as well as external stakeholders as far as the project is concerned. We hope to start the feasibility analysis possibly by November of this year, and then the project possibly by March of 2017. So looking forward to starting that project and getting a lot of support from various stakeholders, including a lot of our government and non-government stakeholders for this project, and obviously thanking the Ministry of Health, thanking the union for selecting Johnson & Johnson as one of the partners for this flagship project that we look forward to working and engaging. Thank you.
Next, we can call Dr. Bornaji Datta,
Do you want to play the
Mission
video?
Tea Free India,
We'll play the
Haryana.
video later. We'll play the video later.
Oh.
Later.
Yeah, at least.
Okay. I think we've managed to reproduce the temperatures of India just to get the atmosphere right. But basically, the private health sector is envisaged to be a significant contributor to the progress towards universal health coverage in India. But the actual configuration and the contribution that it will make is certainly unclear. And the as we move on, thanks. There's been, in the last 10 years, anyone that's been to certainly urban India will have seen an enormous expansion, a burgeoning of private tertiary hospital provision. And it's very unclear what contribution to the wider context of India, with a predominantly rural population, this will make. Sorry, we'll go back. Thanks. The contribution and then community engagement between private hospitals with the wider community is extremely variable. This can be from zero to providing camps, which are very well intended outreach camps that may last for an afternoon or a day, and there's no good evidence that that has any long-term benefit for the community. So our project is from one such institution, which if you want to put it into a box, it's NPPP, not-for-profit, public-private partnership, and we'll describe some of the problems that might engage with that and how they've been addressed. I think there are a lot of potential incentives internal to the institution that could pertain, and some of the more recent ones since the Companies Bill in India in 2013, where 2% of with companies with high income, 2% of their profit margin should go to under corporate social responsibility. And there's discussion still as to how effective that's been, because it can be a tick box and it may avoid actual involvement in community in a more effective way. So that remains to be seen. And I would argue that it's this enormous well of goodwill that I've found when I've been in India meeting people both in individuals and in departments, which can actually provide a pathway into providing real long-term, well-planned and targeted supplementation of a very understrained public sector. The thanks, Marie. In terms of barriers, you've got to convince why on earth should a private hospital, which is income and profit driven, get involved in any of this with a bottomless pit potentially, when they're limited in staff to make a maximum turnover, and in the government and in the public area there are no real close pathways that exist for liaison and discussion between peripheral and rural health doctors and tertiary centres. I think there's significant and possibly appropriate suspicion in the community. So what on earth is this institution doing? Is it just a publicity? Is it a short-term in-out? And could it in fact move resources into into private consumption from where it should be in the public domain? I think that this can be overcome, and we'll see how Benali has got on in terms of it can be overcome by the personal attributes of the individuals and their long-term commitment that is apparent. And I think there's great excitement as we're involved in this project about what could happen for validation of doctors in an under-doctored rural areas under great strain, with high absenteeism, not particularly the DTOs obviously, but below that. And I think there's a lot of capacity for validation and career development which could be facilitated by an external organisation such as a private hospital initiative, which this is. So Benali, I'll let you take over from there. Thanks.
So this entire project that we've now got involved in started with this one meeting with the Ashas, where David and I were involved in a very interactive session with the Ashas. Now, Ashas are the grassroots workers, community health workers, and at the village level. It's an acronym for Accredited Social Health Activists. And this was way back 3 years ago, 2013. And in the midst of this interactive discussion, as we were discussing the problems they faced during their day-to-day jobs of looking after the villagers, they said that one of the problems they faced was that there would be many people coughing and spitting, but to persuade them to come to a health center was almost impossible, and they wanted our suggestions. So that was an input we took back from that meeting, and I just a brief look at what was the existing RNTCP algorithm. It has changed since, but at that time this is what we have. And all I'm trying to show is that on the left hand side with the tick is for the smear positives, which has a excellent setup by the RNTCP, and there's a wide network of the designated microscopy centers, and this group of patients are picked up reasonably well. On the other side, on the other vertical, you have the smear negatives, and these patients, a lot of them are then lost to community because X-ray facilities are not very well available at the periphery. So this was the gap which we felt we could sort of plug along with the ASHA input, and this then led us on to work towards developing a mobile digital van. Now, the hospital I work in, Medanta, already had a mobile van which was fitted with a mammogram in the first instance with all digital facilities, and then we put in an X-ray machine as well, and as you can see, we could see it on screen and print it out then and there to address the patient's need at the time. Now, we started a pilot project in Rewari, which is a district in Haryana adjacent to where our hospital is in Gurgaon, and we carried it out over a 7-month period, May to December 2014. Done very closely aligned with the government, with the district health services. And the gentleman you see sitting there is in fact the district TB officer, who was extremely sort of receptive and a huge amount of commitment from his side, took the project to its completion over a 7-month period, wherein we had 19 visits and we did x-rays for around 355 patients, and we had a staggering sort of 35% x-ray positive. And of course that has then to be taken in the clinical context before they go on to DOTS, and that was done very ably by the district TB officer. Subsequently, as we all know, the call to action TB-free India was launched in April 2015 by the government of India, supported by the USAID and the Union. And as part of the initiative, what we saw Kavita present, they were engaging various personalities, and one of them was Dr. Naresh Trehan, who heads the hospital I work in, Medanta the Medicity. He's a cardiothoracic surgeon by profession, but understands, of course, medicine and TB very well. Now, he attended the Mumbai dialogue armed with this data of the Rewari pilot that we had done. And it culminated eventually in the launch of Mission TB-Free Haryana, which happened in November 2015. And you can see we had, that is Mr. Khattar, the Chief Minister of State Haryana, and you can see Mr. Bachchan there along with Dr. Trehan. And what this then entailed, we already had this experience with this other van which was doing multiple things, but this particular van was a dedicated van now, which was given by the Oriental Bank of Commerce, fabricated by Medanta, and the X-ray machine was given by Philips. So it was really a coming together of numerous corporates and organizations towards an initiative, a public-private initiative. And this is where Haryana is in green. You can see it in the center of the map of India, and that's expanded. It has 21 districts, and what's in red with the circle around it are the 5 districts that we then took on with this one dedicated van. So a hub and spoke model. There's Gurgaon in the center in green, and there are 5 districts, including Gurgaon, around it, and we started covering it every day of the week. So there was a fixed day of the week for a district, and it would go to a pre-scheduled PHC or CHC without chest X-ray and carry forth the testing in a similar manner as we did in Rewari. And this has been going on now from 1st December when it officially started, 2015 till date. So just a broad look at the results. And we used 2 strategies. One was a routine case finding, which was just going one day a week as pre-scheduled, and one was a enhanced case finding, which I think is possibly the way forward, because we put in a lot of effort in distributing pamphlets, and we managed to draw out at least 3 times the number of patients who would have otherwise come for a passive case finding schedule. In any case, I have 9 months results with me, in which we carried out x-rays for a total of 2,899, so close to 1,000, and again staggering 974 x-ray positive, so 33.5% chest x-ray positive and potential new smear negatives. The terminologies have all changed with the new RNTCP guidelines, but I'm just going on what we had started out with. So I think what we carried out was has been and hopefully will continue to be a successful partnership between the government and the private sector. And a few pointers as to what I feel made it work is that we had very clear boundaries and very defined roles. So our job was to go and do the x-rays, and we weren't stepping on any toes, and we did our job and we came back. And of course taking it further forward was the district TB officer and his team, who would then analyze it, decide who goes on to DOTS, etc. So I think that worked well. Now, we were fortunate to have a very committed team who'd go out every day into the district, and again, that's not easy. Doing it on a repeated basis, they developed very good relations with the teams in the periphery, and I think again, that is definitely going to be a positive thing. Committed staff. Now, if there is a committed team out in the district, then that day's X-ray camp is a huge success. So all you need, and not just the district TB officer, but even a treatment supervisor, the STSs, one committed STS, and you'd have an extremely successful camp with outcomes for every patient whose X-ray came positive. Awareness generation, we distributed pamphlets for that worked very well. Very important, state level support and backup, and district TB officer engagement and backup. And I just illustrate this, show this picture where we recently went for a quarterly meeting at the state headquarters for Haryana, which is all the DTOs sat there, and we were part of this meeting as well. And there was a very open, transparent discussion of all their problems and their results, as well as whatever effect our intervention had. And it really felt like we had gelled into one big team, and there wasn't that much of differentiation between private public, and I think that is the goal eventually. Problems faced, of course, there's bound to be problems, and what David alluded to, there is a degree of skepticism and suspicion as to the motives whenever there is private engagement in a ongoing government work. Staff and infrastructure issues at the peripheries, well, it's a vast land width, and that's something I think there is no quick fix solution. That's something we just work at. Lack of awareness, that's important. I think it's important for patients to understand that this is fully curable, and they need to seek help when they are symptomatic, and draw them out to seek health care. Access environment, again, these are part of the environment we live in, and not easy to. So this is the map of Haryana, and I've just given the colors of clusters of districts, and they're divided into 5 such, and there are 21 total districts, and I think it's going to increase in the future, but we'll have vans dedicated to each such cluster doing the same thing. And I conclude with this slide where you can see patients queuing up to get their x-rays done. And really it is to say that they are at the center of all this endeavor for us, launching on this. And we have to see how things pan out, but certainly, so far I think we have made good progress, and hope to keep doing so. Thank you.
We can call Ms. Deepti Chauhan. She will tell about her experience. She went under treatment for the tuberculosis. Deepti, here.
Yeah. Deepti, come. I just want to play the video. So once he's done, play the video. And yeah. So if that's going to play.
What is that video?
Yes. Small video. Can we play? Good. Let's go on. Can you just cue this? Just click. Just play.
My name is Deepti Chauhan. I am an angio TB survivor. I took treatment for 6 years, in which I underwent 2 major surgeries to get my affected lung removed. I want my experience to inspire others to fight and never give up. I was just given 1% chance of survival, but today I talk about my experiences on public platform. I was too young when I got sick. I didn't know what TB meant. But the experience, the struggle I went through has taught me a lot. Today, I work as patient advocate. I want my experience to inspire others to fight and never give up. My message to all TB patients or anyone is never give up. If you fight till the end, I am sure you can defeat TB. India versus TB, TB Harega, Desh Jitega.
Good evening everyone, and this is my first conference. I'm very nervous. So you heard my story. We often hear that TB is a treatable and a curable disease and we can get cured in 6 months. But in my case, it took 6 years for me and I lost a lung. I was just 16. I had entire life ahead of me, but things went wrong. Doctors did not advise the DST at the earlier stage, and that's why the delay in the diagnosis, and it cost me my lung. So as a patient, when I now see and look at things, I feel that it's necessary to follow certain guidelines and certain things if you want this menace of TB to be dealt with and you want to end TB by 2030. The first thing is we have to look at patients as the challenges they face. We can never imagine. Imagine taking 15-20 pills a day for 2 years. It's too long. We hardly complete our 5 days course. So it's important to understand that. TB medicines are such medicines which has toxic side effects, and my vision was affected, my hearing was affected, I could hardly walk, I was vomiting all the time. So it's difficult, it's debilitating. I was not an earning member of my family, I did not have to go out and earn. But think of a person whose household depends on him. If he suffers from TB, how do he look after his family? How do he earn? So when we think of policies and when we make policies, it's important that we make the policies patient-centered. We often think about what the WHO says or how much budget we have. But instead, if we focus on just patients, I think most of the problem will be solved if we just make that care patient-centered. Secondly, how do we go about it? How, as a patient, what do we need to do for the patients? Firstly, if we integrate counseling into the treatment, it makes it easier. I counsel patients, they approach me through Facebook and Gmail, and they often ask me that this is happening to me, what do I do? I can share my experience, I can motivate them, but the medical terms, medical problems they face, I am not educated enough to help them. So we need to integrate counseling into treatment so that whatever remedies doctors can tell them, because doctors won't have that much time for each patient, so we need to integrate counseling. Secondly, when we even take a painkiller, we need to eat something and take. So people with lesser means have no nutritional support whatsoever. They don't know if they would be able to eat in the night. So we have to provide nutritional support to people with lesser means. I'm asking for too much, but economical support would be great. And lastly, diabetes patients or hypertension patients take medicines lifelong, but those medicines don't cause so much side effects. So can't we develop safer drugs and shorter drug regimen for TB patients? Because taking treatment for so long, like 17,000 pills and so many injections, it's beyond, we can't even imagine what a patient goes through. So my appeal to all of you is to unite and let's fight this menace of TB. And I'm sure if we all get together, we can definitely end TB by 2030. And thank you, Call to Action, for giving survivors the platform to share their stories and share their experience, because after all, it's the patient who can, actually help making the policies patient-centered. So thank you.
Now I have to speak. Good evening to all. I think we should not get worried about the activists, because always there is a voice everywhere. You are not able to listen? Yes. Now you can listen? So you should keep the mic.
Yes.
Okay. So what they just now spoken about the activists, we are already working. The bureaucracy system has little delayed because everybody has to cross. I think she knows better, B. Kumar knows better because I was trying to get it done, the Delhi regime, since I joined as a DG. He is telling only 2 years. But things settled because WHO has already put the intermediate regime. So to remove from Delhi intermediate regime to Delhi regime was tough task for me, because there was a force also inside the things. They wanted intermediate regime and Delhi regime. So file was referred to so many people, and then they given the pilot project. But still, I bypassed that, and we say that nothing doing. We will now have a Delhi regime to all over the country by July 2017. It has been delayed because first of all, when we did the Delhi regime's tender, then only one person came forward, the Lupin. So as per the GFR, we cannot place the order to them. So it was delayed, and it was delayed for 4 months. We were supposed to launch in July, but now we will be launching from the 1st December Delhi regime. As far as the HIV concerned, we now have spread to all over the country. And not only that, HIV patients, we have made that the diagnostic tests are easily available to them, and we are covering all over the country. And even prophylactically, we are giving to all HIV patients the INH with the CD4 count is less. So these things, what they have projected, has already been done. And I hope that Delhi regime will be started. As far as the gene expert is concerned, you must be knowing that already country has a 628 gene experts, has been launched in very short time of 1 month, 2 months, because it has been installed in very short period of time. The time took is because of the tendering process and other process and supply. But when it came, it was installed within 1.5 months to 2 months in all part of the country and every district of the country. Not that, even the government of India is now taking initiation to purchase more gene experts, and we are trying to see that gene expert is available especially to the tribal areas and mountainous area where the people has to go long way to get the test done. So this is the other things that gene expert, which is their concern activities, where the gene expert to be launched, it has already been launched, so they don't do it. The other thing, as far as the children is concerned, we have already made the formulas, and Delhi regime has already been going to launch from the 1st December for all the children. So children will go on the Delhi regime all over the country. So this part has also been taken care of. We have a much more what the people think of, much more desire. Now we have planned for a line of actions is a 2017-2020, and our plan is to decrease the incidence rate, not 1.5 to 2%, but decrease the incidence rate by 15 to 20% per annum. And we are trying to decrease the incidence, transmission and mortality. We are targeting the 3 things, that it should decrease by 2020 what the today it is by 1/3. What they say that WHO has projected that 28 lakhs population from the tuberculosis. It was, when I came as a DG, we thought that what we are treating is not for overall disease. The TB is treated in the private sector. Our sector is only catching the poorest of the poor men of the society. Even the lower middle class, upper middle class, and upper class, like Amitabh Bachchan, they all go to the private sectors. Although we have taken in the account of this, but if you see overall the incidence rate, it has definitely decreased. If it has decreased in the public sector from 217 in 1994 to 168 by now, it has also decreased in the private sector also, because the private sector, when they go, and this was the unfortunate part, that DIPA has landed some doctor who is not well versed with the tuberculosis, and they are not able to diagnose properly, and they are not able to treat. So she went to the wrong doctor because it is a high mind suspicion, because you cannot equate every doctors with every systems. And unfortunately, you know, I always tell that we have a two things unreachable. One is a area practitioner and the second is a travel area. If we can reach to them, we can gain the momentum in the tuberculosis patient. But beside this point, we have now coming forwards, and how we have planned now, we have planned in 3-4 ways. We have now planned that we will do the active search of the tuberculosis. I'm just giving one example to all of you that recently we have done active search for the leprosy, and we did house to household search of nearly 40 crores, means 400 million population in 1 week. In 1 week we did 400 million population house to house search, and we are able to take out the leprosy patient which was not diagnosed before, about 38,000 patients which could have never been diagnosed, and we are able to diagnose. The same type of project now we are going to do, launch with the tuberculosis patients, and we are going to make a massive plan to house search even before it becomes visible on the X-ray. We are going beyond the X-ray. We are not going to see the X-ray and the AB negative or AB positives. We are going beyond that. Our plan is now to catch all of the patient at very earlier stage, so that transmission doesn't occur at all. If we can stop the transmission, the occurrence of the tuberculosis will definitely decrease. And with this purpose, Government of India has agreed now, in principle, that we will give the drug only through the public health system, all the drug, whatever the cost it is. So we will be taking the whole